everyone. Welcome again to Global Health Talks. We're talking with a pretty extraordinary fellow, and we find him today in the UK. His name is Professor David Leeper, and Professor Leeper has a stellar background that we could fill a talk just with talking about what this fellow has done. Leeds Medical School, ultimately chairman at Leeds, fellowship with Royal College of Surgeons, so many accomplishments that he's in the marquee who's who as noteworthy surgeon and educator. And that's pretty much top of the heap. So Professor, welcome to our show. We're delighted to have your input and your conversation, and I thank you for being with us this morning.
It's absolutely my pleasure. Pleased to contribute, as always.
Your specific expertise, although you have such a wide range of expertise and come at this from a couple of angles, but let's set some ground rules. Let's set some baseline. Can you tell us what is SSI?
Yeah, it's a widely used expression nowadays. It simply means surgical site infection. And it's one of the healthcare associated infections, which are infections which patients pick up when they come into healthcare journeys, systems. If they didn't come into healthcare, it could be from primary care through to secondary care and back to home. If they pick up an infection along that line, it's a healthcare associated infection. Now, it concerns me because if they didn't have contact with us, they wouldn't get these infections. And they're not simplistic things from a surgical point of view. Some of them are really quite important, and they carry a significant morbidity and mortality. A lot of them relate, healthcare associated infections, that is, to antimicrobial resistance. And I think the world has heard of MRSA, which we're largely getting on top of. But I won't say it's been replaced, but become more important than that now. We're struggling to treat urinary tract and respiratory tract infections, particularly in ITUs, in hospitals, because we've simply run out of antibiotics. I think there's so much been overuse and misuse of antibiotics. These healthcare associated infections have arisen. There's another one called Clostridium difficile enteritis. We were seeing something like 50,000 cases a year 10 years ago in the UK, and a quarter of them died. But we've really got to grips with management of healthcare associated infections. And I think antimicrobial stewardship is just getting better and better and better. And I think the world realizes how important antibiotics are to us. And backing off, it means those infections are reducing. However, surgical site infections seem to kind of stay up there. And in some series now, people are saying it's the most common of the healthcare associated infections. So if I may, let me just kind of subdivide that a little bit more. Surgical site infection, I honestly think we really need to rethink about defining. The definitions that we usually use are based on the level of contamination of the wound edge during or at the end of surgery. So we talk about clean wounds like hernia repairs. We talk about clean prosthetic wounds, like you might put in a hip or a knee prosthesis. And we talk about contaminated wounds, where perhaps you might open the viscous. For instance, you might open the biliary tree, and there's bound to be some contamination at the wound edge from the biliary tree, and that would give you a clean, contaminated wound. With colorectal surgery, particularly if there's a little mishap, a slippage of clamps or a little bit of spillage, we start talking about contaminated wounds. And then ones where, if you like, infection is pretty well established, where you're opening a patient for something like fecal peritonitis, or you're operating already through an established infection, like an abscess. Mm-hmm. And then that's a dirty wound. So that's a sort of simple way of looking at things, but we can go on further with this if you wish, but that's the most basic definition of an SSI.
You know, the impact, when you were touching on antibiotics, Harvard published a study about 5 years ago and came out with a jarring figure. And it related only to emergency room visits. Right. But the figure was 75 cents of emergency visits from parents with children with sore throats are a waste of insurance, time, and money because it's viral and all they can do in the emergency room is dispense antibiotics. So it's a big waste of time and money and cost and everything else. If it's strep, they can identify it. But the reality is there's a lot of overuse and overreaction of antibiotics. Certainly. What is, based on what you've just said, what is the financial impact that you're seeing from surgical site infections? And also bracket it. What is it in the UK, throughout Europe pretty much? What is it given your experience in third world countries? We have numbers here, but it seems to vary quite a bit.
Oh, it does. Just take up your point of antimicrobial resistance, just to tidy that up. I have some sympathy with doctors who are approached with a patient who has a virus or some kind of viral illness that's not going away. And I think there's huge pressures to do something, and giving an antibiotic is just that. But even the simple thing about giving a course of antibiotics, what's a course? And I think we're getting much tighter now on saying, well, you treat an infection until you've got clinical signs that it's gone. And I think that's all part of the antibiotic stewardship story. So that's working well. The costs of SSI, how long's a piece of string? I think the first thing you've got to remember is people have to realize how common it is. And the only way of finding out is adequate surveillance. And I think a lot of my surgical colleagues take a government line perhaps, and they'll say, well, the government's saying we have an SSI rate of 1% to 2%, which is based on inpatient data, which hardly exists anymore because patients go home so early, or readmission data, which again is thin. Not everyone comes home. But I've been looking recently at some very good figures. I've managed to get my hands on Medicaid type data. The databases they have are accurate to the last elastoplast, staggeringly so, very, very effective. And when we looked at colorectal surgery in general, and we looked at over 100,000 patients, can you believe, from these databases.
Remarkable.
And they were recording a 24% SSI rate. This is all types. there are three kinds of SSIs. There's the superficial and deep, incisional, and the deep and organ space. The latter, maybe we can talk about later, but the latter is really a technical thing where there might be a leak from a joint in bowel or something like that. But the incisional in SSIs are things we really can do things about. But when we looked at these colorectal patients, the overall SSI rate, 24%, means they're looking. It means they're being honest.
Yeah.
And what shook us, which was a new finding for us, was that we always talk about after colorectal surgery and soft tissue type of surgery that you look for SSIs for up to 6 weeks, 30 days, that sort of period. In orthopedics, it would be over a year. But in soft tissue stuff like surgery like colorectal surgery, we look at 30 days. And we were finding that a quarter of SSIs in this situation were occurring after that period. So they keep on coming. So again, they're underestimated in incidence, and they're also underestimated in cost. But the cost from this study of Medicaid data indicated that when you were getting deep SSIs or organ space SSIs, they were costing as much as $100,000 per patient.
Yeah.
And you think, wow, that's outrageous, but it's incredible. But in fact, when you look at this, we're talking about patients being readmitted or being kept in hospital. That's expensive in its own right. But when you start talking about revisits to theatre, for debridements, for special treatments, maybe the need for ITU, if the infection has progressed to sepsis, it's a hugely expensive business. And I think it gets overlooked. Quite clearly, healthcare systems are getting their hands on this now, and they realize it's costing their system a lot of money. So they're coming back to the healthcare professionals, particularly the surgeons, and hey guys, you've got to look at this and start doing something about it.
Now, can you comment for a bit, because this directly relates to what you're saying? Implantable devices post-operatively to signal on a around-the-clock basis at the first inklings of either initial infections or return infections. Can you cite a few of those, and can you talk about the inception of these kinds of devices and what you see as the future? Because you cite 28% or 24, I can't remember what you said, but we're hearing even greater. I mean, I heard something in deepest Africa, I heard 38%. And that is mind-boggling, because that means the treatment is far more serious than the initial need for the surgery, or at least on a par with it. So talk to us a little bit about implantable devices, if you could.
Yes, I will, with pleasure. But you talk about these high percentages, but it does relate to surveillance. If you don't look, you don't know. And I think a lot of surgeons in the Western world think their surgical site infection rate is 1 or 2%. If they look, they'll be very quickly disillusioned.
Yeah.
Now, implantation of big joints is a completely different ballgame. It was recognized well over 50 or 60 years ago that if you were implanting a foreign body into tissue, then the number of bacteria that would lead to an infection was logarithmically reduced. Let me give you an idea. To infect a burn or to infect a fairly clean wound, we're talking about inserting at least 1 million organisms, something like Staphylococcus aureus. But if you put a strand of silk into that wound edge, or within the wound, we're talking then maybe about 100 or 1,000 organisms only being required to give you an infection, which might present like a stitch abscess. And it's precisely why we've stopped using silk. Now, prosthetic infections are a particular pain in a way, because they're not common. I mean, even the worst prosthetic joint orthopedic surgeon would have an infection rate of maybe 5 or 6%. But when they have one, particularly if it's a deep SSI, a peri-joint prosthetic infection, it's a disaster. If you're moving in quick, you can treat things, you could maybe nip things off the bud, but once it's established, the skin can completely dehiss over a knee, for instance, and you can actually see the joint in the base of the wound. Now, there's some clever guys that I've met who are saying, well, if you go back to theatre with repeated debridements and lots of patient care, lots of nursing care with good dressing care, you can salvage most of those joints. But if you can't, if the patient progresses from a localized infection to sepsis, and they're particularly ill, then we're now talking about not just the limb being at risk and having an above-knee amputation to save the patient's life, but if it does progress to sepsis, then clearly life is being threatened. So although prosthetic infections are rare, when they occur, it's a big problem. And the orthopedic surgeons will do everything in their powers to reduce that risk.
Among your colleagues in this space, tell me, if you would please, and tell our global viewers, how are you in alignment with what's happening right now? And where do you see the opportunity almost to stand alone in some sort of focus that may help us move this farther, faster, for so many different reasons?
I do a lot of teaching about this, as you're more than well aware, and I'm still trotted out to meet established consultant surgeons of all specialties. And I think the message is still coming along, what I've just touched on before, this concept of education, further education, continuing education. And I think one of the big hurdles we have to get by is getting across this idea of pre-surgical optimization of your patient's health. Getting it right the first time during the operation with the best prophylaxis you can. And I think one thing which I've found actually quite recently, in the last 2 or 3 years, there's a lot of surgeons who obviously must read the surgical journals, and they must see this new scientific appraisal of data, which is called systematic review and meta-analysis. And that's what gives you this level 1 evidence base, the thing that David Sackett talked about, evidence-based medicine at its best. And I think if you open any journal, any decent journal, you'll find one of these systematic reviews and meta-analyses. And within it, you'll see this new statistical table called the forest plot. And I've found, that it's very hard to put a percentage on it. It could be as many as 90 or 95% of surgeons. They've seen it, but they don't really know what it means. and my teaching is, you don't need to understand it. You don't need to be able to do a forest plot. But I think if you understand what it's telling you with odds ratios, in other words, reducing the risk of, say, a surgical site infection, with 95% confidence intervals, that reduction is real and therefore statistically significant, that should change your practice. And I think more and more there are things now that have that kind of level of evidence. Antibiotic prophylaxis, keeping patients warm during surgery, using some fairly novel antimicrobial sutures. They all really do work. And if you put them together in a care bundle, you can really help reduce the SSI rate enormously. But understanding that simple science and statistical background is really quite easy. And I think once you can get that across, they go, that's like a light opens and they say, I've got to change my practice. It's no good being a prima donna anymore or doing what daddy taught me all these years. I'm going to make a decision to change my practice. And that's progress in my view. And it's probably as big a progress, probably much wider effect of that, on the world with global guidelines, getting people to understand this and changing their practice than a surgeon saying, I'm the best surgeon on the planet. I mean, we all thought we were or think we are. I mean, I'm not operating now. But that simple fact of just accepting change is hard to get across. But I think we're beginning to win. And I see people now making big changes, this concept of looking after patients properly, It's really very exciting time.
Yes, it is. Professor, thank you.
An absolute pleasure.
It has been an absolute pleasure for me. I come from a family of educators, and I know when I meet a skilled surgeon /educator, and then I see that kind of reverse to educator /surgeon, I realize you are in the active pursuit of giving us all valuable information from which to move forward and move forward again. I grew up in a country where everything is about treatment, and it's very expensive. But as I've traveled the world, and I have traveled so many different countries, and I come to countries where it isn't about treatment because certain countries can't afford to have the problem in the first place. So it's about prevention, and it's about thinking through why in the world are we afflicted with this, and how can the country en masse bring down this problem to manageable levels. So we're going to keep tuned into you, and hopefully at some future point we'll get some information and we'll bring you back on Global Health Talks. I know that
I would like that.
Well, I find you fascinating to listen to, and thank you for taking this time. Much appreciated.
I can't wait. Thank you.
All right, sir. Thank you, David.